Okay, picture this. A tiny gland, like barely the size of a grain of rice, tucked away in your neck. But it has this huge influence over, well, everything from how strong your bones are to your energy, even your mood. Now, what if that little gland, the one controlling calcium in your body, just goes haywire? There's actually a condition, doctors sometimes use this phrase, stones, bones, groans, and psychiatric overtones. Kind of sums it up, right? Today, we're doing a deep dive into hyperparathyroidism, HPT.
That's right. And basically, hyperparathyroidism, or HPT, means your parathyroid glands are making too much parathyroid hormone, PTH.
Yeah.
And all that extra hormone just throws your body's whole calcium balance completely off.
Yeah, and we've got this incredible set of notes here, really detailed stuff. So our mission today is to kind of unpack all that, cut through the jargon, and give you the key takeaways. We'll look at the different types of HPT, what causes them, how they show up, and really importantly, how they're treated. Think of this as your guide to really getting this condition.
Absolutely. Sure. And it might sound complex at first, but understanding the differences between the types, that's critical. It's how doctors figure out the right diagnosis and the best treatment. Because, symptoms can look similar, but the underlying reason and the treatment needed can be totally different.
Okay, let's dive in then. So someone has high PTH levels. It's not just one thing. Our sources talk about three main types: primary, secondary, and tertiary HPT. Let's start with primary hyperparathyroidism, PHPT. That's probably the one people have heard of most often. So for primary, the main cause, like 85% of the time, is something called a parathyroid adenoma.
Right, an adenoma. It's basically a benign tumor, so not cancer, usually just on one of the 4 parathyroid glands.
Just one gland, usually.
Yeah, usually. But there are other causes too, though they're less common for primary HPT. You can have hypoplasia, which is where all 4 glands get bigger and overactive. That's maybe 10-15% of cases. Sometimes you see that with certain genetic syndromes like MNM, multiple endocrine neoplasia. And then really rarely, less than 1%, you can have parathyroid carcinoma, which is actually cancer. That's much more aggressive.
Okay, so that's what can go wrong. But the how is really interesting too. How does too much PTH actually raise your calcium levels?
Right, so PTH is like the main regulator for calcium. It pushes calcium levels up in a few key ways. First, it tells these cells in your bones, called osteoclasts, to basically break down bone tissue and release calcium into the blood. So it's literally pulling calcium from your bones.
Mining the bones for calcium, wow.
Exactly. Second, it acts on your kidneys and makes them reabsorb more calcium, so you pee less of it out. And third, it boosts the activation of vitamin D, specifically the 1025-dihydroxy vitamin D form. And that active vitamin D then makes your intestines absorb a lot more calcium from the food you eat.
And it's worth noting, too, while it's doing all that calcium boosting, PTH also tells the kidneys to get rid of phosphate. So in primary HPT, phosphate levels might actually be low or maybe low normal.
Correct. That's a key pattern.
Now, symptoms. You mentioned that mnemonic earlier.
Yeah.
Stones, bones, groans, and psychiatric overtones. Let's unpack that a bit. What does it really mean?
Yeah, it's a catchy way to remember how widespread the effects are. It really hits multiple systems. So stones is kidney stones nephrolithiasis. Often calcium oxalate or calcium phosphate stones because there's so much calcium being filtered by the kidneys. Bones refers to bone problems. It can cause osteoporosis, making bones weak and brittle. Or a more severe condition called osteitis fibrosis cystica. That's where the high PTH literally causes thinning, cysts, and fibrous tissue in the bones. You can even get these things called brown tumors. They sound scary, but they're not actually cancer. They're collections of bone cells trying to repair the damage.
Okay, so stones, bones. What about groans?
Groans covers abdominal issues. Things like general abdominal pain, maybe pancreatitis, peptic ulcer disease, PUD, or even just bad constipation. And psychiatric overtones, that refers to things like depression, feeling really fatigued all the time, cognitive issues, sometimes called brain fog.
And on top of that classic list, you might see other signs of just high calcium in general.
Definitely, like polyuria, having to pee a lot, and polydipsia, which is being really thirsty because your body's trying to dilute and flush out that extra calcium. Muscle weakness is common too, and in severe cases, even heart rhythm problems, arrhythmias.
So how do doctors actually diagnose primary HTT? What are they looking for in the tests?
The key labs are pretty distinct for primary. You'll see high serum calcium, both the total and the ionized, which is the active form. Phosphate levels will be low or maybe normal-ish. And here's the crucial part. The PTH level will be high, but it's inappropriately high, given the high calcium.
Inappropriately high, meaning?
Yeah, meaning the gland isn't responding correctly. Normally, high calcium should suppress PTH, but here, the gland is just pumping it out regardless. That tells you The problem is in the parathyroid gland itself. You also usually see increased calcium in the urine.
Okay, and what about imaging? Can you actually see the problem?
Yeah, imaging helps pinpoint which gland is the culprit, especially if surgery is planned. A sestamibi scan is a nuclear medicine test that's really good at highlighting overactive parathyroid tissue, especially adenomas. A simple neck ultrasound can also spot enlarged glands. And a DEXA scan is vital. That measures bone density so you can see how much bone loss has occurred because of the high PTH.
In treatment, what's the usual approach?
For primary HVT, especially if you have symptoms or complications like kidney stones or significant bone loss, the main treatment is surgery, a parathyroidectomy, basically removing the overactive gland or glands. If they can locate a single adenoma beforehand, they can often do minimally invasive surgery, which is great.
But what if someone can't have surgery or maybe doesn't need it yet? Are there medications?
Yes, there are medical options. Cinacalcet is a drug called a calcimimetic. It basically tricks the calcium sensing receptor on the parathyroid gland, makes the gland think there's more calcium than there is, so it lowers PTH production. Bisphosphonates are often used to protect the bones, to treat the osteoporosis, and if someone has really, really high calcium, a hypercalcemic crisis, the immediate treatment is lots of IV fluids and often loop diuretics to help the kidneys flush out the calcium.
Okay, so that's primary HPT. The gland itself is the problem, driving up calcium. But you said it gets more complex. What if the high PTH isn't the cause, but actually the response to something else? This is where secondary hyperparathyroidism comes in, right? Tell us about that.
Exactly. In secondary HPT, the parathyroid glands are actually working correctly in a way. They're pumping out more PTH because they're responding to another problem in the body, usually low calcium or high phosphate. By far the most common cause is chronic kidney disease, CKD. It's often called CKD mineral and bone disorder, or CKD-MBD. What happens is failing kidneys can't get rid of phosphate properly, so phosphate levels go up, hyperphosphatemia. High phosphate actually binds to calcium, lowering the free calcium levels in the blood.
So low calcium triggers the parathyroids?
Precisely. Low calcium is the strongest signal for the parathyroids to make more PTH. Another big cause of secondary HPT is simple vitamin D deficiency. Not enough vitamin D means you can't absorb calcium well from your diet, leading to low calcium again. Less commonly, conditions that cause malabsorption in the gut can also lead to low calcium and secondary HPT.
So the mechanism is different. The glands are trying to compensate.
Right. The low calcium, and in CKD the high phosphate too, directly stimulate the glands. Plus, in CKD, the damaged kidneys are also less able to activate vitamin D, that 1025-year form we mentioned. So that makes the calcium absorption problem even worse. It becomes this cycle, low calcium, high PTH, which then affects the bones trying to get more calcium.
Okay, so how do the symptoms differ then between primary and secondary?
Well, because the underlying issue is often kidney disease or severe deficiency, the symptoms can be a bit different.
You often see more severe bone pain and a higher risk of fractures. This is part of what's called renal osteodystrophy bone disease, specifically related to kidney failure.
Intense itching, pruritus, is really common, often linked to the high phosphate levels in CKD. Vasocalcifications, calcium depositing in blood vessels is a major concern, again, often driven by high phosphate. And then you still get general symptoms like muscle weakness and fatigue, similar to primary in some ways.
And the lab tests must look different too.
Critically different. In secondary HPT, yes, the PTH is high. But, and this is key, the calcium level is usually low or maybe normal. It's not high like in primary. That tells you the PTH is responding appropriately to low calcium. If CKD is the cause, phosphate levels will likely be high, and vitamin D levels are often low.
Any specific signs on imaging for secondary?
Yeah, X-rays can sometimes show changes related to the renal osteodystrophy, things like superior-steel resorption, where bone looks like it's being eaten away right under the surface layer, especially in the fingers. And sometimes a rugger jersey spine, the vertebrae, get this striped appearance on X-ray. It looks like, well, a rugby jersey.
Interesting. So treatment for secondary must be totally different then. You're not usually taking out the glands.
Exactly. The treatment for secondary HPT is all about fixing the underlying cause. If it's CKD, you focus on managing the kidney disease. That means using phosphate binders, drugs like sevelamer or calcium acetate, to lower phosphate levels in the gut. Giving vitamin D supplements is crucial, either the storage form, cholecalciferol, or the active form, calcitriol, depending on the situation. Cinacalcet, the drug we mentioned for primary, can also be used in secondary HPT if the PTH stays very high despite managing phosphate and vitamin D. It helps lower the PTH drive. And of course, for severe CKD, dialysis is necessary.
Wow, okay, so primary is the gland overacting on its own. Secondary is the gland reacting appropriately to another problem. But you mentioned a third type, tertiary. How does that fit in? It sounds like things can get even more complicated.
They can. Tertiary hyperparathyroidism, or THPT, is kind of a consequence of long-term severe secondary HPT. What happens is, after the parathyroid glands have been stimulated to work overtime for so long years, usually, often in patients with severe CKD, they can change. They develop what's called autonomous function. They basically forget how to turn off.
So they just keep pumping out PTH even if the original reason is gone.
Exactly. Even if the underlying problem, like the low calcium from kidney failure, gets fixed. A classic example is after a successful kidney transplant. The new kidney starts working, calcium levels might return to normal or even go high, but the parathyroid glands, because they become autonomous, just keep churning out massive amounts of PTH.
So tertiary ends up looking a bit like primary again, but with a different history.
Precisely. The key feature of tertiary HPT is you have both high calcium and high PTH, but it developed after a period of secondary HPT. The complications are then similar to primary HPT because you again have that persistently high calcium and PTH kidney stones, bone disease, and so on.
And how do you treat tertiary HPT?
Often it requires surgery, a parathyroidectomy, because the glands are no longer responding properly to medical management. Once they become autonomous, removing the bulk of the overactive tissue is often the best way to control the calcium and PTH.
Okay, so stepping back, understanding these differences, primary, secondary, tertiary, it's clearly vital. Because even though high PTH is the common thread, the cause, the calcium level, and the treatment are totally different paths.
Absolutely critical. You can't just see a high PTH number and jump to a conclusion.
Yeah.
You need the calcium level, the phosphate, the kidney function, the vitamin D, the whole clinical context. Knowing the why behind that high PTH dictates everything about how you approach treatment.
And getting it wrong or letting any type go untreated can lead to pretty serious problems, right? You mentioned complications earlier.
Yes, definitely. Across all types that result in prolonged high PTH or high calcium, the complications can be severe. There's hypercalcemic crisis, calcium way too high, above maybe 14 milli-GDL. That's a medical emergency, can cause arrhythmias, confusion, coma. Kidney problems are huge. More stones, calcium deposits in the kidney tissue itself, nephrocalcinosis, and potentially worsening kidney function or even failure. Skeletal issues, severe osteoporosis, fractures, those brown tumors we talked about, and cardiovascular effects too. High blood pressure and those dangerous vascular calcifications, especially common in CKD-related HPT.
It's also worth just briefly touching on things that might look like HPT but aren't, right? Other causes of high calcium.
Good point. Differential diagnosis is important. There's a rare genetic condition called familial hypocalciuric hypercalcemia, FHH. They have high calcium, but low calcium in their urine, and PTH is often normal or only slightly up. It's usually benign, doesn't need surgery. Cancer or malignancy can cause high calcium, but usually the PTH level itself is low, suppressed. The cancer might be making a substance called PTH-related peptide, PTHRP, that acts like PTH. And taking way too much vitamin D can cause vitamin D toxicity. You'll see high calcium, but again, the body's own PTH production will be suppressed, trying to compensate. So the PTH level is key.
Okay, this has been incredibly clarifying. Let's try to quickly recap the core differences one more time. So, primary HPT, high calcium, inappropriately high PTH. The gland is the problem. Treatment is often surgery.
All right.
Secondary HPT, low or normal calcium, appropriately high PTH. The gland is reacting to something else, like CKD or low vitamin D. Treatment targets that underlying cause.
Exactly. Fix the cause.
And tertiary HPT, high calcium, high PTH. But this happens after long-standing secondary HPT. The glands become autonomous. Treatment often involves surgery again.
You got it. That's the framework. You know, this whole discussion really highlights just how incredibly balanced our body's systems are, or supposed to be. It's amazing how this tiny little gland, the parathyroid, has such profound effects everywhere. Bones, kidneys, gut, brain, heart.
It really is. It makes you appreciate the complexity, the ripple effect of even small hormonal changes. And it makes you wonder, what's next? As we understand these pathways better, maybe more personalized treatments are on the horizon. And, how many other subtle signals are our bodies sending that we haven't fully decoded yet? Signals that tell us when things are just starting to go off balance. Makes you think.